For this next one, we're going to do the Ferris technique. So for this anterior shoulder reduction technique, basically going to bring the arm out, keeping it initially adducted, and just grab the patient's hand like you're giving them a handshake. And for this one, I'm going to pull back with inline traction, and we're just going to be oscillating up and down, okay? And you don't want to do anything super quick here, so we're just going up and down about 10 to 20 degrees of angle, and you'll notice that you start coming while you're abducting out. So you're starting to come out in this direction, and just keep going up and down. Sometimes your patient will reduce right here, but if not, you just keep coming in this direction, and you're coming out until you hit about 90 degrees. So once you hit your 90-degree angle here, you then need to externally rotate the arm. And so now it's externally rotated. I'm continuing my inline traction, and we're coming up and down, and frequently it will reduce around the 120-degree angle. All right, once you feel that clunk of a reduction, you can go ahead and place the arm across the chest and get it immobilized. This next technique is called the Davos technique, and this is a really good one if you have a motivated patient who is going to be willing to help you out with the reduction. So the first thing is we're going to kind of strap the hands together. So if you have them just kind of put their hands together like this, I like to just use Coban. You can use tape, and I basically just put that around their wrist to hold those together. This kind of increases compliance of your patient because now they can't pull their arms apart. But if they can just grasp their hands together, like if you were on a field or you were in the forest and you didn't have all these supplies, they could do it without the strapping. So the next part is they're going to bend their knee. So knee comes up, and they're going to go ahead and put their arm up over the knee like this. Everything is going to be done slowly because they're going to be in some pain here. I have had patients just reduce just by getting them into the correct position. But the next step would be for the practitioner to go ahead and sit on the foot to just stabilize it. And you're going to have your patient just lean back. So looking up towards the sky, and then just keep leaning further and further back. And that'll just put more and more inline traction on their shoulder. And you're basically trying to fatigue the muscles here. So they'll stay in this position, usually 2-3 minutes, although sometimes I've had it happen immediately. And those muscles will fatigue and the shoulder will reduce.
Next, we're going to be doing the Snowbird technique. I find this technique to be the easiest because it uses the least amount of upper body force, and most people's legs are stronger. And so if you have your assistant place the sheet through the affected axilla to apply countertraction for you and keep the patient upright. The patient's typically sitting at the edge of a stretcher or on a chair that won't move and without handles. You'll take, if you're in the emergency department, a leather restraint or hard restraint and patient in the patient's affected antecubital fossa. If you're on a sideline or for game coverage, you can always use a belt or some other form of strap or even a sheet tied together. You grasp the patient's distal arm and their antecubital fossa, and you have your assistant apply countertraction. You'll gently step into your restraint and or belt to apply downward force. After about 30 seconds to a minute of gentle downward force with countertraction, the shoulder should spontaneously reduce with a clunk.
This next technique is the Cunningham technique. This is a technique that focuses on massage in order to relax the muscles and facilitate the reduction. It's really important to get the patient appropriately positioned in order for this technique to be successful. So on the bed, as you can see here, I have my patient sitting as upright as possible. You want them to bring their shoulders back and open as much as they can. All right, and if you can't get them into the bed or if you have it available to you, I find that this is easier to be done in a chair in the patient's room. But if they're up in the bed like this, have them in this position. Then what I'm going to do is come next to them on the bed here. And the first step is just having them place their hand up onto your shoulder. And you want to do everything really, really slow because what we're trying to do is not increase any spasm to the muscle. So our patient's going to put their hand here on my shoulder. I'm going to put my hand down in their antecubital fossa and just pull a little bit of inline traction. Right? If you're causing any pain, it's going to increase the spasm. So everything is just going to be nice and slow. With your other hand, you're going to start massaging the bicep, the deltoid, and the trapezius. And you basically are just going back and forth between those three muscles. And I'll usually do this for 60 seconds to 2 minutes of just massage. Sometimes just the massage itself will relax things and the shoulder will reduce. If after doing that much massage and feeling like the muscles are not tense, it still hasn't reduced, the next step, I tell the patient this might feel a little bit weird, but I'm going to have them shrug their shoulders up and back. And as they go up and back frequently at that time, the shoulder will reduce. Sometimes it takes 2 or 3 times of having them shrug their shoulders up and back in order for the reduction to take place. You should feel a clunk since you're right here, and then you can place the arm in a safe position.
Next, we're going to do the Spaso technique. You'll stand on the affected side of the patient, grasp their distal forearm, and apply inline traction. Your assistant will apply downward force at the AC joint to stabilize. Then you slowly start flexing at the shoulder to about 90 degrees, taking care to avoid pain. And this process typically takes 30 seconds to a couple minutes to fatigue the shoulder muscles. Once you're at 90 degrees, externally rotate to allow for spontaneous reduction.
This technique is scapular manipulation. We have our patient prone here. The first thing I'm going to do is find the angle of the scapula. And so I found that right here. And the goal of this is to move the angle of the scapula towards the patient's spine. So just take my 2 thumbs and I'm pushing medially. So trying to push that angle of the scapula towards the patient's spine. You can help things out. For me, on this patient, it would be my left hand along the superior aspect of the scapula, and I'm pulling it down. At the same time, my 2 thumbs are pushing that scapula medial. What's nice about this technique is that instead of manipulating the humerus, it's manipulating the glenoid fossa to open up and allow the humerus to reduce. This is also a nice technique to add to a number of the other techniques we've shown, especially if you have a healthy patient. You can hang weights on their arm, which is called the Stimson technique. You can also use this one with the Spaso technique. So if you don't have weights and you have an extra helper, you can have the patient, while you're doing scapular manipulation, you can have somebody pulling inline traction. Otherwise, if you were holding, hanging weights, that would be the Stimson technique, and you can just do this as a one-person technique. The weights are being hung, and you would perform scapular manipulation as we showed before. I'm going to talk through the Milch technique. I typically like to do this one when the patients are sedated, although you can use intra-articular lidocaine. And I like to have a helper for countertraction. And I like to get that sheet up into the shoulder as much as possible. And I like to get this done before the patient receives any sedating medications. That way they can help us out. So first thing, the patient's arm, the elbow, needs to be as adducted as possible, so it needs to be up against their side. And then I just take my left hand and I put that, if it's the right arm that's affected, I just put that into the antecubital fossa. And then that allows me to use my body weight to really put down inline traction. So with putting that inline traction down, I'll come and start to externally rotate. And I externally rotate that arm to about 90 degrees. The entire time I'm putting inline traction. Once you hit 90 degrees, I start pulling towards me with inline traction as I abduct up to 90 degrees. If it hasn't reduced at this point, what I'll do, continuing that inline traction, is I'll go with externally rotating the arm, and this is a pretty exaggerated external rotation. So they're coming as if they're reaching back behind them to grab something, and frequently at this point you'll feel the clunk of a reduction. At that point, just place it and get it into a shoulder immobilizer.
We'll be demonstrating the traction countertraction method next. You'll have your assistant place a sheet behind the patient and through their affected axilla. And then we'll place my sheet through the patient's forearm. And again, letting it land in the antecubital fossa. We'll have the patient lay flat on their back at this point. Your assistant and you will be applying force directly opposite of each other. And so your assistant will pull back and I'll lean back very gently, again, holding right here. This doesn't take a lot of force. It just takes some time to fatigue the muscles, typically 30 seconds to a minute or so. After this, you'll feel a clunk and the shoulder will spontaneously reduce. Lay it flat across their chest. This is a posterior shoulder dislocation, which is much rarer than the anterior shoulder dislocation. For this, you'll grab the distal forearm and the elbow. You'll apply gentle downward traction at the elbow. Increase the adduction and internal rotation of the shoulder. Bring the elbow up to about 90 degrees of forward flexion. And externally rotate the shoulder. And this will cause a clunk and hopefully spontaneous reduction. Here we have Luxatio-erecta, which is an inferior shoulder dislocation where the patient's arm is stuck in this elevated position. You'll have your assistant place a countertraction sheet in the affected trapezius, and you'll have your patient lay flat on their back. From this position, you'll grab the proximal humerus and apply gentle inline traction to disengage the humeral head from the inferior glenoid. At the same time, you'll hyper-abduct the shoulder. And at this point, typically after 30 seconds to a minute or so of fatiguing the rotator cuff muscles, the shoulder should spontaneously reduce at that point. We have another case of Luxatio-erecta, an inferior shoulder dislocation, and this way we're going to try and avoid bringing it anteriorly and reduce it with one attempt. And so you'll have an assistant applying inline traction to hopefully disengage the humeral head from the inferior glenoid. At the same time, I'm going to be applying force here over the humeral head to keep it posterior so it does not come anteriorly. And so if you apply traction that way, we disengage the humeral head. At the same time, I'm pushing it back, up, and into the fossa, and then the shoulder should spontaneously reduce. We have another case of Luxatio-erecta where you have an inferior shoulder dislocation where the patient's arm is stuck in this upward position. You'll have the patient lying supine on their back. With my left hand here, I've placed it on the proximal humerus posteriorly, and with my right hand, I'm going to place it on their medial epicondyle. I'm going to push forward with the left hand on the proximal humerus while pulling at the same time backward and down on the medial epicondyle to produce an anterior dislocation. Once that anterior dislocation is produced, you have an arm that is now anteriorly dislocated. And you will then do a second step which is whichever one of your other techniques that we've taught you today to reduce that shoulder effectively.